And I have to, oh, let's see. Do I have to share slides in some way? Is that how I do it?
So whenever you hit the share screen function down the bottom, it'll let you
Okay.
pick, specifically. You don't have to share your complete screen. I only share like what I have to share, which is the PowerPoint itself. So I have the PowerPoint
I'm
already.
I may have to have someone do it for me
It's
since I
okay.
don't have it easily
Oh no,
accessible.
you're fine. I got you. Just tell
Thank
me
you.
when you want me to do next slide
Sure.
and we'll do it that way.
All right.
All
Thank
right.
you.
Of course.
All right. So I'll be talking about goiters today. We'll do a little overview of, what that means, what is a goiter, how to evaluate it, and then how to manage it going forward. And I'm sorry, I have these AirPods in, and so it kind of blocks out sound, and I'm sitting in quite possibly the squeakiest chair I've ever been in my life. So it may squeak the whole time. So I'll try to minimize my movement.
No worries.
Next slide. So what is a goiter? I know I have a lot of slides here, so could you go to the next one for me, please? So a goiter is really just an overview word for any irregular growth of the thyroid gland. It can be overall enlargement of the gland. It can even be asymmetric enlargement if you have a nodule on one side that's making either the left or the right side look bigger than the opposite side. So it's really kind of just an umbrella term. So, any thyroid gland that's not 100% textbook normal, like the pictures that you see. And it's actually recognized as a reimbursable diagnosis by insurance. I mean, it's an ICD code I've actually used within the last week, actually. So next slide, please. So this is just one of the drawings or pictures of what a normal thyroid gland looks like. So not a goiter. It's a normal in size. I know it's not an actual person's neck, but next slide. This is a goiter. So I found this picture on the internet. If you just type in goiter, you'll find a whole host of interesting images. But goiter is just, here on the actual person, that is just symmetric diffuse enlargement of the gland. And then here's some images at the bottom denoting that, a goiter can just be a gland that's asymmetrically enlarged if you have one nodule, or there's multinodular goiter. It says toxic at the bottom here, but you can also just have a person that has normal thyroid function and just has a bunch of nodules making the whole gland look enlarged. Next slide, please. So I know I mentioned that already. So multiple things are described as goiter. You may see we see a lot of people referring for goiter, and it could mean they have one thyroid nodule or the whole gland is enlarged in size. Next slide. So the average weight of a thyroid gland is around 25 grams. I don't think that they usually put that in most ultrasound reports, but they oftentimes will put in, or they always should put in the measurements. So height, from top to bottom, the average height of an adult thyroid gland is about 4 to 6 centimeters. So if you see one that measures like 5.5 centimeters in height, that's okay. That's normal. And I like to keep these numbers kind of in the back of my mind when I'm looking at reports, because they always give you all 3 dimensions. And then the average thickness, that's front to back, that's 2 to 3 centimeters. And then average width, so side to side, it's about 1.5 centimeters to 2 centimeters. And sometimes, that's why it's always good, and I don't want to go ahead of myself, but you'll see me that I've recommended doing ultrasounds. That's because sometimes you'll look at a person's neck and they're a thin person, or they just have the type of neck where the gland sits more anteriorly and it seems more prominent, but it's not actually enlarged. So it's always good to do, a full assessment. Next slide, please. So, what are some of the causes of an enlarged thyroid gland or a goiter? So worldwide, if you look at, everywhere, the most common cause is iodine deficiency. Really, that's not a, concern in the United States. I know people have asked me that in my clinic before, but so many foods here are fortified with almost said iron, iodine. It's in so many things that really you just don't see that much in the US. I've never seen it. Now, in the United States, the most common causes of a goiter would be things like Graves' disease, which is autoimmune hyperthyroidism, a chronic autoimmune thyroiditis, which is Hashimoto's disease, and that typically leads to hypothyroidism, and then multinodular goiter. Less common causes would be malignancies, either an actual thyroid cancer itself or lymphoma can cause a rapidly enlarging goiter. And that's really scary. Thyroiditis, sometimes the thyroid gland gets a little bit inflamed and kind of swollen, and then it usually gets better. You can see that after pregnancy or even after illnesses. And then infiltrative disorders, that's things like sarcoidosis and amyloidosis, some conditions that can infiltrate the thyroid gland and kind of just make it look larger. Next slide. So once you see a patient in your office, you see that they have a goiter, sometimes you may not even see it first. They come in with outside imaging that says the gland is enlarged. Well, you want to know a few different questions. So one, is it causing any problems with how big it is? So that's a lot of times achieved with history and physical exam. The patients will, I don't want to jump ahead to some of my other slides, but, some of the times the patients will report certain symptoms that I'll get to here in a little bit. I always ask myself, is there any thyroid dysfunction? I know I talked about the most common causes in the US being Hashimoto's, Graves' disease, and multinodular thyroid. So you want to check a TSH to see, are they hypo or hyperthyroid, that you need to do further evaluation for that. And then are there any nodules? So that's where your ultrasound will come in handy. Also that, and just for the measurements of the gland. And then, as a summary, what's the cause of it? It's good to know what the cause is. Next slide. So, should you worry or not worry if they have a goiter? So some of the things that I touched on before is it causing any problems for the patient? Sometimes they'll report trouble swallowing or the sensation that food gets stuck and they're having to, drink water with it. They less commonly will have some hoarse, in my, from the patients that I see, hoarseness of the voice or changes in their voice. They might cough because when they lay down in bed at night, the gland is kind of choking them, for lack of a better term. And they may just feel like something's sitting on their neck when they lay down. So I always ask them, do you lay flat in bed at night or do you have to sit up because of this? But yeah, the choking sensation, I've often even asked patients if they reach up into cabinets to grab something, are they getting that choking sensation when they do that? And we'll kind of talk about that on one of my next slides. Could you go to the next one, please? Thank you. So that's one of the things that I'll talk about is Pemberton's sign. And we can go ahead and go to the next slide and I'll show you the picture here. So basically what you have patients do and how to do a Pemberton's sign is you'll have them raise their arms up above their head. And what that does is it kind of makes the thoracic inlet smaller. And if you have, that's a fixed space that gets a little bit smaller when you raise the arms up. And so there's already not a whole lot of space in there for things to travel. So anything that's larger there, like a thyroid gland, can obstruct the venous outflow. So it'll kind of push on the jugular veins and then the blood won't drain from the head. So their face can get really red. I consider it a positive Pemberton sign if they even have symptoms. So say their face doesn't turn as red as this patient's. This is like a classic picture that everyone puts up. It's because it's so pronounced. But I've had people where they don't necessarily have that, but they'll feel like they're choking and they feel like they're coughing. I mean, I had a lady that I did a video visit with that started coughing and almost fell out of her chair. I thought I was gonna have to call EMS to go and get her. I mean, she had a large goiter, but as I kind of put down here, the thyroid almost acts like a cork and nothing can go, up or down. And what I usually have people do is, the Pemberton sign, I'll time them for a minute, but if they turn this red, like this photo, I mean, you can have them put their arms down. That test is positive. Do not pass go. Okay, go to the next slide, please. So if they have this, they need surgery. I mean, it's causing problems. Maybe not while they're just walking around, but anytime they make that thoracic inlet smaller, there's obstruction. So that's an indication for surgery. Next slide, please. So, back to the goiter, just in general, you want to make sure that it's actually their thyroid. So if you say you feel a goiter, but you send them for an ultrasound and their thyroid's within normal size limit. If that's the case, it's really unlikely to be the cause of their symptoms. We see a lot of people like that in our clinic. They're having trouble swallowing. And if their gland is normal in size, I hate to say anything with 100% certainty in medicine, but I'll tell them, look, it is highly unlikely to be the cause of your trouble swallowing. So if you see that in your clinic, you probably want to evaluate it further and don't put all your eggs in one basket, and make sure they get a swallow study, a barium swallow. A lot of people have, indigestion reflux that's causing some, issues swallowing. Next slide, please. So if you have somebody that has a goiter, but it's not causing any obstructive signs, they're not feeling, they're asymptomatic and they don't have that Pemberton sign, and you don't see any nodules, then really that's just cosmetic. And most people aren't really bothered by it. But if they tell you, I really don't like the way this looks, I'll at least offer them to go to a surgeon. So a lot of it's just reassurance to the patient, like, this is nothing to worry about. We'll just keep an eye on it, especially if it's nodules, which I'll kind of talk about later in the presentation. Next slide, please. So I recommend checking a TSH to screen for thyroid disease when you get a patient that you think has a goiter or has one confirmed on an image. So, what if there's a goiter and it's not causing any compressive signs and symptoms and the Pemberton isn't present? So, if the TSH is abnormal, you want to investigate for any underlying causes of hyper or hypothyroidism and treat those appropriately. With Hashimoto's, the chronic autoimmune thyroiditis, that typically leads to hypothyroidism. Over time, years down the road, the gland will most likely shrink in size, just because you're giving them exogenous thyroid hormone replacement. But the whole reason that the gland gets large to begin with is because you have that TSH, the thyroid stimulating hormone from the pituitary gland, that's telling the thyroid, hey, make more thyroid hormone. And the gland's dysfunctional, but you're getting that chronic stimulation of a gland. It's kind of like if you're a weightlifter and you're lifting a whole bunch of weights, your muscles get bigger. You're stimulating the gland and it's just growing, but it's not able to make enough hormone. So that's why it happens in that case. Graves' disease, which is autoimmune hyperthyroidism, the whole reason that the gland gets larger in that case, and it's more of a diffuse enlargement, is because you have these thyroid stimulating immunoglobulins, these antibodies that are attacking but making the gland overact or overwork. So there's chronic stimulation there still, and the gland will get larger. And usually with Graves' disease, I tell people, a lot of times if it's really active Graves' disease, there will be some associated swelling. But even if you treat the hyperthyroidism, the gland doesn't get that much smaller. If it gets smaller at all, it's usually just from any inflammation that's in that area. Next slide, please. So, one of the other things that I talked to you about as far as what the most common causes of goiter would be, multinodular goiter was one of those causes. You can also just have a single nodule. And those need addressed too. So I'll be talking about thyroid nodules, but they're still technically goiter. So we'll talk about how to manage those. Next slide, please. All right. So if you see or you feel a thyroid nodule on your exam, I would first order a TSH. You can do it at the same time that you order an ultrasound. That way you get both. But if the TSH is low, then you're going to want to do some additional testing before you decide, does that nodule need biopsied or not? Sometimes the person will have a low TSH and it's because they have a hot nodule, or the nodule itself is making too much hormone, but the rest of the tissue is working just right. If the TSH is normal, then no uptake and scan is needed, ultrasound, and, assess that if appropriate. And we'll talk about which nodules that would need looked at closer. Next slide, please. So of all thyroid nodules, what I usually tell people when they come into my clinic is they're really common. So if you pluck like 10 people off the street, probably at least 3 are going to have nodules. And the majority of them are benign. Actually, about 95% or more of all nodules are benign. And so when I see a patient, they start getting worried if I tell them, you might need a biopsy. And I usually try to reassure them, we monitor them going forward because it's kind of like freckles. You go to the dermatologist to make sure those don't turn into cancer, kind of the same concept. So, it's not always about the size of a thyroid nodule. we look at the size as well as the features of the nodule. And I have that in a picture that I'll show you here in a little bit, but even smaller nodules can have cancer. So it's not always a good idea when you have nodules to say, yep, biopsy the biggest one. You want to look at that, or, we will look at our images and make that determination based off of the American Thyroid Association guidelines. And then people might ask you, well, is it bad if I have 5 nodules versus just one? Not necessarily. Just because you have, I've seen patients, and I do actually the fine needle aspirates, the biopsies here at the hospital. I've seen people that have tons of nodules, and I biopsy 3 of them at a time, and they're all negative, they're benign. And then you biopsy the person that has one that looks like it's probably not a concern, and it comes back cancer. So it really just doesn't matter the number, it's what they look like. Next slide, please. So I know I kind of harped on this already, but the reason we care is so that we don't miss one of the nodules that just happens to be cancer. Even though it's a small percent, that's what we do. Oh, that's okay. You can go ahead. Thank you. So how do we know if there's cancer in a nodule? Do we order the nuclear thyroid uptake and scan? Hopefully everyone says no. Next slide, please. Remember that nuclear thyroid uptake and scan, and sometimes I'll see that people have ordered that. Really, the utility of that nuclear thyroid uptake and scan is to help you figure out why they are hyperthyroid. So it won't help you with determining whether they have cancer or not. Now, certainly, if you order a thyroid uptake and scan for another reason, and the radiologist wrote on there cold nodule, that absolutely needs addressed. But for just general workup of thyroid nodules, you wouldn't need a nuclear thyroid scan and uptake. So answer is no. Can you read my slide here? I feel like I get on a roll and then I've already read everything that I would read to you anyways. Yeah, so I pretty much said that. We'll go ahead and go to the next slide. All right, so ultrasound is absolutely the best way to look at the thyroid gland. CT, oftentimes your patients might go into the ER and get a CT for some other reason, and they incidentally note that there's a nodule there. The best way to look at those nodules is an ultrasound. So if they're seen there, you still want to get the ultrasound just to better characterize them. The only time we would ever get an ultrasound and then subsequently order a CT scan, which is usually a soft tissue neck, is if that gland is huge or we think it's going below the sternum, or subclavicular, substernally, and extending into the chest wall. And usually I order that if I'm worried about that, because I'm already shipping them to the surgeon. And the ultrasound won't go through bone. It just lights up, so you can't see anything past the bright white bone. So next slide, please. So what do you do if the ultrasound doesn't show any nodules? You really just follow them through time. You can monitor their TSH going forward. It's really going to be best with an exam, physical exam. And if you see their gland is getting even larger over time, that'd be a time in which I would say, ultrasound it again, and possibly check their thyroid function again. But really your physical exam is handy in that case. Next slide, please. So then what do you do next if the ultrasound does show nodules? I know I kind of started talking about this a little bit, but we'll talk a little bit more about, nodules and criteria for which you would biopsy. Next slide, please. All right, so this is just a picture of a nodule. Usually they give you the image and the transverse view, and they measure these nodules in 3 different dimensions. In this case, that 2 is the front to back dimension. The 1 is the side to side. I know I mentioned on my first slide, and the side to side should be, oh gosh, now I'm not even going to remember to quote my own numbers. So top to bottom, it's 4 to 6. Front to back, it can be 2 to 3 centimeters, and then side to side should be about 1.5 centimeters to 2 centimeters. So we look at them in all 3. Next slide, please. So, we can see the nodule on the ultrasound. We know how big it is. We also look at the appearance. I never just look at a report, and that's why I'm kind of obsessive about often getting the ultrasounds done in our facility. Not always, but I always like to look at my own images, and all of us usually do in our clinic. So after we get all of this information, the next question is, should we biopsy it or not? And we'll talk a little bit about that. I think my next slide is the picture. All right, perfect. So if you're ever, at your own clinic and you're thinking, I don't know if I should send this, first of all, we're always happy to see any patient. But if you have a nodule and you're thinking, I don't remember, is this a scarier nodule or is it not? You can just Google ATA thyroid nodule guidelines. And if you click on images, oftentimes this is the picture that comes up. It won't tell you all this stuff on the side here, but I'll go through that. So on the left side, it will tell you kind of the risk of it being malignant. So these higher suspicion nodules, I won't read every single thing here, but these are going to be nodules that really look irregular. They don't have a well-defined border. They may have some calcifications inside, like the first image on the top left. And then, or calcifications around the rim. So those are higher risk nodules. And those are, there's a 70 to 90% chance those could be malignant. So those are high risk nodules. And we biopsy these nodules at different sizes based off of what they look like. So the two top categories are either intermediate or high suspicion. Those get biopsied if they hit a centimeter or larger. Then as you work your way down, they're lower risk nodules. So what I'll tell people, and if they're, sometimes I'll show them a picture if they really have a lot of questions, but when you're presenting it to patients, you can say, look, this is a lower suspicion nodule. About 5 to 10% of the time it's cancer or something to worry about. I'll flip it around and I'll say, 90 to 95% of the time, this is not going to be anything to worry about. And those low suspicion nodules get biopsied at 1.5 centimeters. And then these, the second to last row here, we call these types of nodules, particularly the one on the far left, is a spongiform nodule. And those I find are really common. So if you take a dish sponge, that's kind of what this looks like. It almost looks like if you shove down from the top down, that you'd be able to compress it. Those are pretty low risk, but if they hit like over 2 centimeters, we would still biopsy it just because the malignancy transformation potential increases at that point. And then these simple cysts at the very bottom, those you really don't have to worry about. They're usually just fluid filled and you don't have to do anything with that. Okay, next slide. Thank you. So if the report shows multiple nodules, you can only pick one. How do you make a decision? Sometimes I'll see orders that says just biopsy the biggest one. And that's not always the right case or, the right answer based off of what we've just talked about. I mean, you might have a spongiform nodule that's that lower risk nodule that's pretty large, but then you've got one that's smaller, but it has all these calcium deposits inside. So it's not always the right answer to pick the biggest one. Next slide, please. So if the report shows multiple nodules and you can only biopsy one, how do you pick? I went ahead of myself a little bit here. So B is off the table. You're not going to just biopsy the biggest one because who knows, it could just be a cyst. Do you want to defer it for 6 months? Probably not. If it's a higher risk nodule, there's a chance that it could spread. So the answer is to biopsy the nodule that has the highest risk. You can actually go ahead 2 slides because I think I have the answer on the next one. Yeah, thank you. All right, so this is kind of going back to that first picture that I had on there. You'd want to biopsy. I always try to be as specific as possible if you're ordering it. And I mean, certainly, if you're not sure and you're not comfortable ordering it, we are always happy to look at the patient, look at the images and, send it once they get to us. But I always try to be as specific as possible. So rather than saying biopsy the biggest one, if you actually look at the images and you know which one you want, just tell them, biopsy the 1.3 centimeter. I think I already talked about all this stuff, so I can go to the next one. And this is just the picture again for reference. So when I send people for a biopsy of their thyroid nodule, I usually give them at least a heads up because now, especially with our EMR, which is Epic, everyone gets their result within, I don't remember what the time is, but sometimes the patients will see it before I do because if I'm running my clinic, it's kind of hard to be looking at my results. So I usually just give them a general idea of what potential result they could see. So benign is usually the most common because remember, 95 or more % of nodules are benign, not cancer. You can usually just repeat the ultrasound in a year. And if it still looks the same size at that time, you can space apart how often you're monitoring it. Sometimes we'll get an insufficient sample, so they just didn't get a good enough number of cells to make a diagnosis, in which case I usually send people back for a repeat biopsy in about 1 to 3 months. I don't do it right away, just give them a little bit of time to recover. You can have suspicious for thyroid cancer or it's thyroid cancer, no ifs, ands, or buts. And in that case, you would refer to either an endocrine surgeon or ENT, as well as sending them to us, because if, when they get diagnosed with cancer, we do long-term follow-up for those patients. So it's good for them to get plugged into both. We would also need to, determine what further treatment the patient may need after surgery. And then you can get this result that I'll tell people about where it's called atypia of undetermined significance or follicular lesion of undetermined significance. I usually tell people that just means the cells look a little funny. They're not sure if it's cancer or not. So then they just send it off for some extra testing. And it's genetic testing. They test for specific mutations that are often seen in thyroid cancers. And if they're positive, it'll kind of give you a risk assessment or a risk of what the likelihood of that nodule is that it's malignant. And I've had, usually they'll come back if it says benign, it'll say around a 4% risk of malignancy. I don't have a lot of leeway with that. If it says the 4% chance of it being malignant, I'll just watch those. But if it says 50-50, they go to surgery. That's too much of a risk in my eyes. And they'll either get a total or a hemithyroidectomy. Next slide, please. So when should you order an ultrasound? This is specific for the thyroid nodules, specific to the whole talk being about goiters. You can order an ultrasound. You should order an ultrasound if you feel a goiter and if you feel a nodule. It's not usually if you're just seeing a patient in clinic and you are doing just a regular thyroid evaluation. The best way to do that is just a TSH. But if you feel something, either a goiter, if you feel a goiter, so either a diffuse enlargement of the thyroid or it feels nodular or one side feels larger than the other, just go ahead and get the ultrasound and it'll show you what you need to know. It is important to know though, I've had patients where I've done their I've done their physical exam and one side's just bigger than the other. And sometimes that happens. Sometimes the thyroid gland itself is a little shorter and then it's kind of chunky. So front to back, it's a little bit bigger, but it's shorter. Then I've had people that have a really long gland, but it's thin. So everybody's different and both lobes aren't always the same size. Next slide, please. And then just a couple last pieces of information. So a lot of times on the ultrasound report, you'll see the radiologist comment of what the gland looks like, heterogeneous or homogeneous, and what does that mean? Next slide, please. So if you're looking at this tennis ball, although it is one solid color as far as it being yellow, you can kind of see that the surface is kind of granular looking, and it's not just one solid sheet of a color. And that's kind of what they mean when they describe it as heterogeneous. It's just a more coarse texture. And when they call it a homogeneous texture, that just means it's one solid color. It's less grainy looking in appearance, and it's just has more of a smooth appearance. Next slide, please. All right. I feel like I went really fast, but maybe not. Does anybody have any questions for me?
That was great, Jen. Thank you.
Thank you.
Yeah, that was really wonderful. I'm over here like feeling my neck. Is anybody else? Over here like,
do I have a goiter?
Yeah, seriously. You explained that really, really well. No, you did a great job. Really appreciate that. That was excellent.
Oh yeah, thank you.
Of course. Yeah, does anybody have any questions or comments they want to add?
or anything I didn't go over that you have questions on that I was hoping to get it all inclusive and in the time that we have. So
Well, if you do have any questions, of course, pass it our way, and I can always reach out to Dr. Turner for any of those questions. And while we're on here, please remember to submit some cases. We haven't had one in quite some time, so that'd be great. Oh, Dr. Polywall, go ahead.
Yeah, thank you for the presentation. My question is that how long, if the nodule is unchanged, that you can stop monitoring it with the ultrasound? You know, many of the time we order the ultrasound and the radiologist says, oh, repeat in 3 months, 6 months here. So, but when they put in the official report that they need a repeat ultrasound, then as a family practitioner, we are bound to order more. But at the same time, you know, sometimes the patient, due to their age and distance from the testing site, they want to avoid it.
Sure. Yeah, it does make it hard when they do that. So sometimes if I've had a nodule, and I think we all do it generally the same. Dr. Giordano, if you have anything different once I finish, please feel free to chime in. But usually what I do is if the nodule has been monitored and it's been stable, depending on how long you've done it, for 2 or 3 years, if it's one of the higher risk looking nodules, I would say maybe still keep an eye on it, but push it to 2 years from then, because it's reassuring that it hasn't grown in a couple of years, and I think you can push it back. And then if it still hasn't grown at that 2-year mark,
I think that's definitely reasonable depending on what your patient really needs. I mean, a lot of elderly patients, just like Dr. Polywall was saying, it's really hard to get transport. So then I'll just mention, if you're having neck symptoms, if you start to notice like odynophagia, dysphagia, voice changes, shortness of breath, orthopnea, then please call the clinic. And even though we may not have an ultrasound that's routinely scheduled, we can always do one, you know, if they start to notice any kind of neck changes.
But I usually give it a couple of years. I mean, if it's stable, then that's really reassuring.
Mm-hmm.
Okay, thank you.
I think the reassuring thing too for us, you know, for providers and for patients, is that even if it is thyroid cancer, most thyroid cancers are very benign, indolent, like slow growing cancers. Most of the time it is papillary thyroid cancer, and that truly is a slow growing process that most people will die with instead of because of. So I think that's a reassuring thought too, that, you know, we always want to consider the hardships for the patient and what the risk is of allowing a nodule that's maybe grown slightly or changed. You know, what is the risk to them in the long run? And most of the time, papillary cancer is very slow growing. It's typically not a threat, you know, to the patient's life. So I explain that too, because I have a great many people in the geriatric population that say, I don't want to get any more ultrasounds. I would rather just, you know, whatever's in there, let it be. And I think that should be offered to them. That should be something that we talk about. You know, no monitoring is okay too.
Well, that's the goiters that you've been talking about, and the cancer type, whatever. This is not connected to diabetes and kidney disease in any way, is it? That's one thing I don't have yet. I don't want it.
So I always, not so much type 2 diabetes, because type 1 is an autoimmune disease. Sometimes you can see an increased risk for having things like Hashimoto's or even Graves' disease, because if you have one autoimmune disease, you're at a higher risk of having another. But not so much with type 2 diabetics. I know with my type 2 diabetics, I'll screen them for thyroid disease like once a year. I just get a TSH just to make sure I catch it if they have it. But there's no direct relationship that I'm aware of. It's mainly the, you know, type 1 when you have an autoimmune disease.
That sounds good.
So don't worry.
Thank you so much, Jackie. And thank you, Dr. Polywall, for the question and the comments from Dr. Giordano and Dr. Turner. If we don't have any other questions, I'll go ahead and give you some minutes back, 15 minutes back to your day. And our next session will be taking place on the 27th. And we will have Smita Kumar discussing osteoporosis. So thank you again. And I hope you guys have a wonderful day.
Thank you.
Thank you.
Thank you.